So, because I know this was towards the end, and you guys were kind of zoning out and getting ready to listen to psych and take a break, we're going to briefly just recap the aortic aneurysm, and then we'll look at some of the pictures of kind of what it looks like, okay? So remember this one in patients, asymptomatic in a lot of patients, right? The screening stuff is what's important. Definitely the men, right? And just look at that. That's 100 cigarettes lifetime. For those that don't smoke and don't know, that's 5 packs in their life. If they have smoked 5 packs or more in their life, they buy themselves a screening. Okay, a screening. Why? Because it's asymptomatic, right? We want to catch this prior to it rupturing when we're talking about the aortic aneurysm, particularly the abdominal region, all right? So, you got your different things here, the chest x-rays, what your initial study, your abdominal x-ray, depending which aorta you're looking at. Your CT is your study of choice when you know there's an abnormality, okay? Your CT is your study of choice when you know there's an abnormality. If you're screening, I'm not going to ask you a screening question because that's not radiology, right, looking at the stuff, but know when you get to other classes, your screening is actually an ultrasound. Now, why would I, if CT is my study of choice, to actually like look at the abnormality, evaluate the abnormality, figure out what's going on with it, why would I do an ultrasound for screening? Right, so it's, the CT is still pretty quick, but it's no radiation, right? And it's screening, which means the majority of your patients aren't going to have an abnormality on that abdominal aorta for that aneurysm. So if I know I'm going to have to screen a large portion of the population, I'd rather use the non-radiation method to just get a look at the size of the aorta to determine if I need further testing to see how bad it is, right? So if you know from physical exam, when you guys are doing that, you're like, oh, this is already large. You don't need to do the ultrasound for the screening because you noticed that. That's why we kind of teach you to try to find it, right? So you find it, you're like, oh, this is probably an aneurysm. We're going to go ahead and do the CT because that is going to evaluate the true size of it. It's going to evaluate whether or not there's a dissection starting, which we'll look at here in a little bit. And we're trying to actually diagnose the severity of what's going on. And that's why the CT is a study of choice for the abnormality of aortic aneurysm. But if we're screening patients, we don't know that they have an aortic aneurysm. Now we're just screening them. We're looking for it. We're not going to pump everybody full of contrast and a CT, right, with the radiation just for screening. We're going to use the ultrasound. That will tell us the size as well, but it won't tell us what's going on the inside, right? And then we can go from there. Yeah?
So our palpation technique is only for descending aorta, though. So if you have an ascending aortic aneurysm,
yes,
you can't even really see that on like transducer ultrasound.
Correct. So good question, right? So he said that if this goes in here, right, the palpation technique is for your abdominal one, right? That is your primary area of testing when we do the screening. It's the abdominal. So you are correct. You won't be able to see the thoracic. However, more common than not, these people who have the tobacco use or have the weakening is in the abdominal aorta region, not necessarily in the thoracic region. Okay? So when you're doing the screening, you are screening the abdominal aorta. If you are concerned for whatever reason for thoracic aortic dissection, the odds are it's going to be with the symptoms and what's going on, you're going to jump straight to the CT because they have that transesophageal ultrasound, but like we kind of talked about, that's going to be a cardiology order. You guys aren't going to go ahead and order that. Okay. So we looked at this again, right? Just to give you an idea, this is the thoracic aorta. And this is where this one talks about the contrast study of choice for the thoracic aorta aneurysm or dissection, and how it kind of will get larger or more than 50% the normal size. Don't get hung up on the numbers. The numbers are important for you to where if you see a study and it's more than 5 centimeters, you know you need contact surgery. You know you need contact surgery because that could rupture, right? And I get this question all the time on the clin skills. Well, hey, what if it's more than 5 and I'm palpating? Couldn't I rupture it by doing my abdominal kind of test and everything? Good, but you don't need to, if it's that bad, you're not palpating that hard, right? You guys are going to be able to see it or feel the pulsations pretty good. So you're not walking up and just smashing on the stomach looking for the aorta. You're going to do gentle palpation until you find it. So it's still pretty rare to have it this large, and then also I don't think I've At least I haven't. I don't use downward medicine, like I said, but I haven't heard of anybody rupturing an abdominal aorta by doing the palpation. I'm sure it's happened, but I don't think very often. But, so yeah, so there's your sizes. Atherosclerosis is the most common cause of this, and then smoking as well. We'll add into that because it weakens those vessel walls. Okay. Oh boy, this looks like the uncoiling of the aorta and hypertension, right? Yeah. So how would I know on this? There's that, right? Even maybe a little bit here, maybe a little bit there, but really that guy there. How do I know on just x-ray whether this is an aortic aneurysm or whether this is just uncoiling of the aorta due to long-standing hypertensive cardiovascular disease or any of the other things we talked about? X-ray alone, I don't. I have no idea, right? And especially if the patient is asymptomatic and they're coming in, I have no idea. So what am I going to do with this patient next? CT with contrast to further evaluate that to figure out what the heck's going on. So this is one of those examples where you see, right? You get an x-ray as the initial study and you go, oh, this could be 3 or 4 different things. If I have a patient presentation that leads me towards one or the other, I can develop a most likely, right? You can develop most likely. So for example, if this patient did not have hypertension in their vitals, or states that they do not have a history of hypertension, or maybe has hypertension but has been well controlled on medication for the past 5 years and still has vitals that are normal, right? I'm leaning away from this being the cause of something like hypertensive cardiovascular disease because of the fact that they don't have that. So now I'm thinking maybe aneurysm, right? So using sometimes some of those things will kind of help you delineate over what might be going on here. But ultimately, this patient is going to get a CT with contrast because we're in the aortic aneurysm section, because that's what we're doing, right? So that's where kind of pieces some of that together, because this is not enough. And that's why, especially for this test, I say look at the picture last. Understand what I'm asking for, and then use the picture to help you decide. Because if you start with this on an exam, you're going to spend a lot of time looking at that, trying to piece it together, and then you get to it, you're like, oh, I just need to know what to order next, and you're going to have hypertension, so it's a CT with contrast, right? So, help benefit you guys there. All right, so you see that there. That's how bad it can get. So this is the entire thoracic aorta. I got it written right there. 67-year-old man. Not only is the descending thoracic aorta large, enlarged, right? But also, we have some of the ascending kind of sitting out here as well. This is gnarly. What's that? That is a wonderful question for a vascular surgeon. I have no idea. Or cardiology. I absolutely have no idea if cardiothoracic surgery is going to go in and do anything for this. At a minimum, they probably need to be on beta blockers to bring that heart rate down and bring the pressure down. Even if this isn't due to hypertension, right? I want to bring it down to make sure there's no extra pressure on there. I have no idea what the definitive treatment would be on this guy. Here's one that's a little more subtle. Here's one that's a little more subtle. Bless you. What we have is right in here. So I'm going to go back to my normal. Here's my normal in this region. So by knowing that, and then go back here and I'm like, man, that's really kind of sticking out there. Now, is that the aorta? Is that some kind of mass? What's going on? Maybe I don't know. You will know by the end of it, by the end of this block, because we are going to talk about masses, particularly cancers that might appear in that area, what kinds of symptoms those patients will have, right? So let's say we are concerned about a cancer. Are they having any of the cancer type symptoms? Are they having any fevers, unexplained fevers, night sweats, coughing up blood, depending on which one it is? We'll talk about that in a later lecture. So by the end of this, based off of the patient's symptoms and presentation, you'll be able to formulate whether you think this is maybe a aortic aneurysm or a potential mass or a cancer based off of how the patient's presenting. What do I notice here on this X-ray compared to the hypertensive cardiovascular disease ones? What is not present? Cardiomegaly, left ventricular hypertrophy. Look at that left ventricle, right? So now this leads me to believe that this is from a different cause potentially. This is definitely not from long-standing hypertensive cardiovascular disease because of the fact of I don't have an enlarged left ventricle yet. Right? That's going to be probably step one before I even get to the aorta. Because trying to work harder is going to get bigger. Good. Jumping into specifically the thoracic. Same thing, guys. X-ray, initial study. CT with contrast, study of choice. Same as the other aortic aneurysms. All right? Same thing. Transesophageal ultrasound can use to diagnose it, but you're not going to order that. Cardiology is going to order that. Okay? But the difference between the dissection and the aneurysm is that tearing, ripping back pain. That tearing, ripping back pain. Yes, aneurysms can lead to dissections, and they often will, if not treated, and not necessarily treated to make the aorta smaller again, but treated to lower that pressure that it's experiencing. Okay? So this is that same one from before. The reason it was so large is this patient actually has the dissection, but I didn't say that then because I want you to see the x-rays look exactly the same. Okay? The x-rays look exactly the same. But now look at my CT with contrast. Okay? X-ray, I can't really make a whole lot out. Heck, even this one here, I have a little bit of an enlarged, bless you, aortic knob, but it's not super prominent like some of these other aneurysms and dissections we've already been looking at. So I'm not really sure. Why did I suspect this? This patient reported that tearing, ripping back pain. And what you're seeing primarily here on my sagittal view, the bright white is the main part of the aorta. That's the main aorta. What you're seeing behind it is somewhere in here, one of the layers of the aortic wall, from AMP, there's like 3 wall layers to that aorta. One of those layers from the pressure got a small tear in it. Blood, because of pressure, got in between those 2 layers and started going down and started ripping and tearing the cell wall layers apart. And so now what you have here is almost like a pseudo aorta behind this wall layer where some blood and therefore contrast is getting in. And that's what your aneurysm looks like. It's contrast in both, but one is more than the other because a little bit's getting in behind that wall tear. This is surgical. We need to fix this because the longer it goes, the bigger it gets. It will go all the way down to the abdominal. It can split off into the renal arteries, the splenic arteries. It can go down to the iliacs. It can just continue to go down. How do they fix it? I don't know. It's just surgery. You surgerize on them. But that's what the dissection looks like. If this were just an aneurysm, you would just have a really wide aorta, and it would be all the bright white contrast. But it would be much larger than some of the normals that we've seen. You wouldn't have contrast in a second area kind of sitting posterior to it or around it right here. Which is why that sagittal view is going to be one of the best views to look at to see this, because here I'm like, what is going on around the aorta, right? Especially at a beginner's level. But then when I see this, then I can do that kind of thinking of like, oh, there's my layer, and I got contrast right behind where the main aorta is supposed to be. Does everybody see that? Tearing, ripping chest, not just chest pain, right? Regular chest pain is regular chest pain. This is a very specific type of chest pain because they're feeling that they were layer kind of rip down and just heal down like you're opening a Ziploc bag. And I would say, what is this? We just spent yesterday and part of today looking at it. Aortic aneurysm. questions on that slideshow? All right, give me a minute to switch out. All right, what do we got here? First of all, what type of study is it? CT, what slice? Axial, good job on those questions, by the way. Oh, okay, I heard pneumothorax, I like it. Or a hemothorax. Can I have both?
Yes.
Absolutely. Absolutely. Just put the words together. Pneumothorax. Pneumothorax. And we'll look at some of these things and what they look like on x-ray, but then all good. Airway stuff. Parenchymal lung disease. Oops, turn it off. There we go. Okay, so much like the fluid, we have two types of lung disease. We have our airspace or alveolar lung disease, and we have our interstitial or infiltrative lung disease. Okay? So again, much like our fluid, our alveolar has that fluffy cloud-like appearance because the disease is within the alveoli. There's a bunch of those guys that do little pouches. The alveoli are little balls that, kind of in the lungs that do the air exchange. So that's going to look patchy. It's going to have that cloud-like or hazy appearance overall. Can't really make it out. The margins aren't really clear because of that. They're distributed throughout the lungs, or it may be localized. Gee, thanks for that. Right? I mean, depending on when you catch it, the hint behind that is depending on when you catch it. If you catch it, it's just hitting a couple of those alveolar sacs, alveolar areas, and it hasn't gone diffuse yet. That's why it says it can be localized, but it'll get worse and it will be diffused by the end of it. You may contain air bronchograms. What are those? Well, we're going to look at those. Okay? And that's going to kind of give you a hint that it's an alveolar space disease. Your interstitial or infiltrative, reticular nodular or reticular nodular patterns. Basically lines, dots, or lines with dots. Okay? We'll see pictures of it. The interesting about this is you have Packett's disease and you have normal lung in between. So you can have like disease, normal lung, disease. Right? So you can have a gap, a healthy lung in between it. Usually it's very kind of like there's the disease and you can kind of see where it ends, see the lines. It's not kind of hazy, kind of grainy looking sometimes. We'll see what those look like. And we don't have air bronchograms. And we'll talk about why we don't have air bronchograms when we see what those things are within the alveolar space diseases. These are all the possible diseases. We are not covering all of these. But you will see all of these throughout your course here and throughout phase 2 at some point. Okay? So these are all the possible things that could be going on. We will cover a couple of them, right? But there's too much to cover in this block alone. But where this helps you is when you get into pulm and you get into other things, if you understand which ones are alveolar and which ones are interstitial, when you get an x-ray on your pulm test, if you can read that and understand which one it is, it narrows down your differential of what you're trying to figure out because you know which one is which. So that's why it's in there. FYI slide, not testing on these things, but this is an alveolar edema throughout the entire set of the lungs. See that patchiness, that fluffy, hazy appearance. Pulmonary or alveolar edema is just what it says. It's fluid in the alveolar space. Now, we kind of talked about this back in the congestive heart failure lecture when we were talking about different things. Even though it's fluid, it's still an airspace disease because the issues with the airspaces, right? The fluid is within the alveolar sacs. That's the problem. So we're seeing some stuff now for a second time, but then breaking down the different disease processes as opposed to just recognizing, hey, this is alveolar versus interstitial. So there's a bunch of fluid sitting in the alveoli, so we got pulmonary edema in there. And then over here, we have a pneumonia. Okay? It's nice. It's kind of isolated in an area. This is where I say like it could be localized. That pneumonia will get worse, right? If it goes untreated. But then my question is, if you didn't see this up here, what lobe would you say this is? Right lower lobe, I have it labeled, right? I'm pointing right lower lobe. But if I didn't have it labeled, could you tell me what lobe that is? No, I need the lateral. That could be lower or middle. I have no idea because those lobes overlap. I would need the lateral, okay? So it is a right lower lobe on this one, but I absolutely need the lateral. What you're starting to see, and this is what I wanted to make sure, you'll see some better pictures of it later. I want you to look at the white arrow, right underneath the white arrow, okay? So the black arrows are kind of pointing to where the pneumonias are, but look at just above, underneath that white arrow. Do you see, and if not, that's fine, we'll see other ones like this, kind of how it's light grayish, but then in the middle, it almost looks like this darkened tree branch that's sitting in there. Can you see that? Can you appreciate that? Right in here. That is your air bronchogram. What that is that pneumonia is causing inflammation in fluid, okay, within the alveolar area, alveolar space, and that fluid is basically like a background of where the little bronchioles are going, and so it's causing an air bronchogram. It stands out because of the fluid, and you can kind of see that little tree branch. That's what an air bronchogram is. You're like, wow, so the parabronchial cuffing, I just get that nice little circle, right? It just surrounds it. This is a little bit more involved, and it's actually kind of just laying in the alveolar space. And you're like, oh, I can actually see that whole bronchiole. I can trace it out. That's an air bronchogram. We'll see some other ones, but I wanted to point that out right there because that's pretty subtle, but that's what it looks like. That's another sign. Let's say you haven't gotten the pneumonia this far yet, but you notice the air bronchogram. That's a sign that this is some type of alveolar space disease. What's your differential? What are you going to do for them? Are you going to read the X-ray later and go learn all that at home? Here are all the things that can cause fluid in that airspace. Congestive heart failure, we already know that. All right, covered that one. Blood, any type of pulmonary hemorrhage from trauma, any other kind of area there. Gastric juices, aspiration. So if somebody's throwing up a lot, vomiting a lot, they aspirate their vomit or their gastric juices, that can cause inflammation in the lungs. That can cause more fluid to kind of show up. That gastric juice is super irritating and can cause alveolar space disease. Inflammatory exudate, that's big fancy word for that's what pneumonia is. Pneumonia is the infection, it's inflammatory, we have exudates because the body's trying to fight it off, and that's what the pneumonia is. And then post-drowning victims or post-near drowning victims, inhaling a bunch of water. Those are all things that can cause issues. Now for those of you who said I was crazy, and you were in your head, and you didn't see that air bronchogram, here's one that's a little more prominent. Okay, now, notice what happens on x-rays sometimes, especially chest x-rays, when you zoom in a bunch. That image gets really kind of grainy and pixelated. But it really shows that air bronchogram really, really well. That's why I did that, so you guys can actually see it. So again, this isn't a problem with the bronchioles. This is a consolidation or fluid buildup behind it. It almost puts like a background, so it kind of pops just a little bit more, and you can end up seeing where the airways are going. This is a sign of the airspace disease. Okay. Another one we have is our spine sign. Right? Remember, the thoracic spine is supposed to get darker as it goes down. You can use this for multiple things. So if I trace down, it goes darker as I'm supposed to get down. Okay, oh, that's brighter than the one above it. Right? Fine, darker, 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 brighter, brighter than the one above it. Okay, something's not right here. Okay, so far, what have we talked about that's not right? One of the things we talked about is cardiomegaly, right? That heart can be infringing on the spine. Well, Look at my PA, that's not cardiomegaly. So that spine sign is not from the heart, right? What that red arrow is showing you, okay, that red arrow is showing you the pneumonia. Boy, that's really hard to see because the heart's hiding it. I'll buy that. I agree with that. That's why we use both pictures together, because then your sign is going, hey, what's going on down here? What's going on in this region down here? Why do I have that spine sign? The patient's feverish. They're coming in because they're sick. They've been sick for a few days, or they've had sick contact. I give you all those pneumonia type signs. And then I ask you, what's going on? And you'll have, like, I don't know, right lower lobe, left lower lobe, right middle lobe, left middle lobe, that kind of thing. And you'll have some x-rays and you'll go, hey, I noticed a spine sign there. I got symptoms of pneumonia. So which lobe is it? I'll use the PA to figure out, is it right lung or left lung? And then the lateral to figure out what lobe it is. Yeah.
Can you trace the heart on the lateral?
So the heart on the lateral is this guy right here.
What's the dark spot in the superior portion of the heart?
Right here?
No. In the.
You said superior portion of the heart here.
In the heart, like the arrow. Like where the end of the white.
Like right here?
Yeah.
So that's just some lung tissue, right? That's not in the heart, right? Remember, we can't tell what's in the heart just based off of the lateral. We're just looking at where the heart generalized is, so the heart's just sitting right in here. This, I would say, is probably just normal lung tissue, right? Because the heart comes up, and then you start to get your vessels and your great vessels that kind of come up and go together and everything, so that's probably a space right there that's doing that. But we don't know that that's necessarily in the heart, because it's not like in the knee of the heart, and other than that, we can't really tell. Yeah. Black arrow is just showing you where the scapulae are. Okay? So that's your spine sign. Again, showing you again, it can be multiple different things. You see the spine sign, you then go to the vignette to figure out what's going on with the patient. X-ray is not enough. Now we have something called silhouette sign. Well, this is a new one. Okay? What silhouette sign is when there's two objects that are supposed to be next to each other, but you can't tell where one ends and one begins. So on the first picture on alpha, it's the right atrium and that consolidation, right? I can't make out this line of the right atrium that well versus the consolidation because they're silhouetting against one another. That shouldn't be there. I should have soft tissue of the right atrium and I should be able to see the lungs. Let's go back to this one right here. See how the right atrium is nice, clear cut, and then I have lung tissue right after it, okay? But then when I go into this, where's that right atrium end, and where's my lung tissue start? I can't really tell. So that is a silhouette sign. Combining that with my lateral, I can see my heart here, but then there's something else going on that's kind of sitting right over the heart, at least on the lateral picture. I see my heart kind of there, but then I got this other brighter white grayish area. Definitely can kind of see it's shaped a little bit differently than my heart normally is. That's a silhouette sign. I can't see the edges of my heart. I can't see the edges of the heart here because there's something else overlaying it. Something that's the same radiographic density. You're going to see why these things are going to be important here in a second. I'm going to have a chart that's going to kind of explain how these things can help you determine what's going on as far as where the lobes are and things along those lines. So again, looking at how we call these airspace diseases. So spine sign is looking at the thoracic spine. They're supposed to be darker as they go down. When they don't, we call that spine sign. Silhouette sign is when we have two things overlapping one another. So the borders are blurred. I can't tell where one thing ends and one thing begins like it's supposed to. That's silhouette sign. That can happen anywhere. Right here in my right hemidiaphragm. Here's my normal. Here's my right hemidiaphragm. I can't tell you where the diaphragm ends and where this abnormality begins. That's a silhouette sign. Does that follow? Does that track? Why is that important? Remember how I told you, in order to figure out where these things are and what lobes they are, what do you need? A PA and a lateral to definitively say this is left upper lobe, right middle lobe, whatever the case may be. Well, what happens when you have that sick patient that is inpatient or in the ICU and all you can get is that AP chest x-ray? I can't get a lateral. You can't do laterals portable. There's too much. We don't have the technology to make them a good image. It just is fuzzy, nasty. You can't make anything out. So you only get the one frontal view. And you start to see a silhouette sign. You're like, I think I have pneumonia. I think I have some kind of consolidation or some abnormality. Well, where is it? In the absence of a lateral, you can use the location of your silhouette sign to make a most likely educated guess as to where the abnormality is and what lobe. Right? So the one we just looked at, the right hemidiaphragm, if I can't get a lateral, I'm going to say it's probably the right lower lobe. Just based off of this chart and kind of where that sits. Is it 100% accurate? No, it is not. You have to get a lateral to confirm the location. But in the absence of a lateral, when you can't get one, you still got to make your best medical guess, right? They call it practicing medicine for a reason. You're making your best guess with the knowledge and information that you have to get to what you think is going on and where the issue is. So you can use this chart and the silhouette sign to make an appropriate guess. So if you can't see your ascending aorta area, so really that aortic knob kind of area, it's going to be like right up in here. If you can't see this, like the spine, I know that it doesn't stick out very much, then that's going to be considered right upper lobe. So if you can't make out the end of the spine, or where maybe there's a little bit of ascending aorta here in the lungs, and that's all grayed out, that's your right upper lobe. The right heart border, that right middle lobe. So that would be this guy right here, the right atrium, the right heart border. That looks low. It does. But remember that middle lobe sits right in there. And it kind of goes along. You got your lateral, right? And when you look at your lobes on your lateral, you're like, oh yeah, that's that nice little triangle lobe that's right over the heart. But if I didn't have this, the right heart border is going to be your right middle lobe. Right heavy diaphragm, right lower lobe. And then the same basic thing on the left side. Now if you notice the left side, the upper or lower, left heart border, okay, maybe left upper, which means if I'm going to give you a test question on it, if I'm going to use the left side, really the only one that's clear cut is the left hemidiaphragm for the left lower lobe. No, your hemidiaphragms are your lower lobes. Right one's all pretty clear. Left one, there's some gray area. Can't give you an academic question with gray area. And then right afterwards, we have our lobe pictures again to just kind of show you why we go with most likely. So, in particular, look at the yellow circle here on my right lung. Most of that, almost the entire lobe, is over where that right heart border is. This is why we'll say, you know what, it's probably right heart, or right middle lobe if it's over that area. Yes, absolutely, it could be lower. But it's the only area that encompasses the entire middle lobe, so we're just going to go ahead and say, hey, it's most likely that. Also why the hemidiaphragm is going to be lower is because we got this section that's lower. Sure, it could still be middle, but again, it's an educated guess based off of the silhouette sign. We're going to go with lower if it's the hemidiaphragm. You can see now too why we do the upper lobe for any of the thoracic or ascending aorta area. It's really the only thing that's kind of in that area. Again, in the absence of a lateral film. If you have a lateral film, you don't use silhouette sign, you use the lobe to figure out exactly where it's at. So here, if there's a question with a silhouette sign sitting right here, obscuring the right heart border, and I also give you a lateral, and you see the spine sign in the lateral, it is not right middle lobe. It is right lower lobe, because I'm giving you that extra information to confirm that location. So silhouette sign again, in the absence of a lateral, is when we use that to make our educated guess. So if you have a lateral, we can confirm it. Same thing with the left side. Just kind of showing you that picture again. This one's a little more clear, hemidiaphragm, right? But then that's why this says the left heart border is in the lingua of the upper lobe, so like down here, but it's still upper lobe. And the descending aorta, yeah, it's probably both. It could be either or. There's too much overlap in those areas for us to make an educated guess of knowing for sure where it's at in that descending aorta area, and then even here in the left border of the heart. So we just, for us, hemidiaphragm is what I care about, the left lobes. So this is for you to go back, right? And kind of when you're looking at the chart, you're trying to see, hey, did I learn it? I have these nice little blue slides that break down some of them to tell you, hey, I got this. I understand this chart. If I see a question like this or I see a picture like this, I'll be able to pick out the lobe of what's most likely going on. Also, for some of you who noticed that there is I put all the blue slides again for block 2 in the review section. It's just all the blue slides together, just for ease for you guys to kind of just quick study. It's not all inclusive, it's conceptual, but yeah. Questions on the lobe, the silhouette sign, the spine sign, any of that? Now let's talk about what infiltrative disease looks like. So this one's a little bit different. This isn't in the alveolar space, right? So it's not going to be patchy like we've seen before, okay? Connective tissues, lymphatics, blood vessels, bronchi, all of the tubular things, right? Although we saw an air bronchogram with the other airspace disease, the alveolar one, the issue wasn't with those, it was with the fluid behind it, right, in the sacs. This is issues with all the tubular things. So which is why you can have areas of lung that are separated by normal tissue. So for example, you can have nodules distributed throughout. You can have a reticular pattern distributed throughout, but then have lung tissue just above it or just below it. I already said this, but it's here in words. Reticular means lines, nodular means dots, reticular nodular means both. Here are 3 different pictures of what they look like. Let's take a minute and kind of go through this. First of all, on my reticular, not patchy, right? Those are definitive kind of lines and networks going on. I can make out, if I really wanted to, I can take out a really thin pencil and I can trace all of these guys, right? And I have like some healthy lung tissue in between, right? Oh look, there's darker there because I have the lines and all that, right? So that's my reticular disease, crisscrossing lines. This one in particular is sarcoidosis. This is what this looks like. Okay, I'm not going to make you do that just off of an x-ray. It's not one of the disease processes we talk about specifically with its own topic slide. It's not something I'm going to have you try to pull out, but you will see sarcoidosis again in Pulm. Okay? Now we go into our middle one, which is nodular. All these dots. Circle, dot, 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 dot. Most commonly, if you see this, metastases. Right? These are cancers. This particular patient, thyroid cancer. These are metastases from a thyroid carcinoma that have gone into the lungs. Unfortunately, we see this often. And then reticular nodular is a combination of both. Know that reticular nodular is a combination of both. If I ask you to pull it out, I'm going to give you the reticular or nodular, right? Because it's kind of tough. The little dots are the nodules. And then we gotta have the lines all over the place too. I more want you to understand that if you see reticular disease or nodular disease, that is infiltrative interstitial disease different from the alveolar. Okay? Different from the alveolar. I'll show you a few more pictures and kind of take a look at some of this stuff. Here's another one. So this one here is a varicella pneumonia. Got all the little nodules in there. And by those of you who are like, hey, is this reticular too? It's very possible, right? That's why these things can combine, they can become two at the same time. Typically, if you're seeing a nodular disease that's from like a pneumonia or a virus or a sarcoidosis, it can be both, depending on what stage you catch it in. If it's just the nodules a lot of the time, we're concerned that it's probably a metastases like we talked about just last slide. Here's a big old adenocarcinoma, this big old circular mass bordered by the black and white arrows. How do I know it's adenocarcinoma? We'll learn that in a later lecture. Symptoms and location. Okay, there's the most common area of these lung cancers and kind of where they can present, and we'll talk about that. Yeah, okay. So adenocarcinoma, did that big mass jump out at you guys? Right, as far as abnormal. By the end, you'll know what it is. How would we, if I suspected adenocarcinoma, this is just funsies, how would we confirm that? Anybody know? Yeah, we're going to send them for a biopsy. We're going to make sure. We're going to send them for a biopsy. Okay, so what are some of the things that we are going to see that are specifically to the interstitial disease, right? We talked about the alveolar disease, we briefly talked about pulmonary edema, but then we talked about the pneumonias and the different lobes, and then alveolar space disease. So the infiltrative one, we could have, oh look, pulmonary interstitial edema, so fluid in the interstitial. Why does it happen? Lots of different reasons, right? Increased pressure due to CHF, congestive heart failure, we keep circling back to that one, right? So that can cause these issues. Allergic reaction, don't worry so much about the lymphangitic blockade, it's possible, we'll talk about that more in pulm. But what do we find? Fluid in the fissures, parabronchial cuffing, pleural effusions, and apparently deep lines. That was congestive heart failure. Congestive heart failure is an interstitial disease. It's an end-stage interstitial disease. But if I had started with the broad disease processes and tried to explain all, we hadn't seen it yet. That's why I start with CHF. It has all of those abnormalities. You see what they look like. You understand why it's happening. And then you're like, oh, okay, I get this. So congestive heart failure is an interstitial disease, right? So here's the fun part about this. Very few physical exam findings on this. Why? It's not in the airway. When you're listening to the lungs, you're listening to the airway. You're listening to the air going in and out, that air-gas exchange. When the fluid is in the interstitial and not in the airway, not in the bronchioles, not in the alveolar sacs like a pneumonia or something is, you don't hear any wheezing, you don't hear any rales, you don't hear any bronchi because it's in the interstitium of the lungs. It's in all the tissue surrounding it. So a lot of times, your physical exam findings are normal. Yeah? Would that be detectable percussion? It depends on how severe it is, right? Depends on how severe it is. If it's a really big consolidation, then yes, you may notice a difference in percussion. But if it's early on, then it's not, say, thick enough, right? Then probably not. So that depends. Right? A lot of this stuff that's not CHF related clears by itself because the body's really good at reabsorbing fluid that's not supposed to be there. So a lot of these things will just kind of clear on their own if it's just an intermittent thing. If it's lasting longer than 48 hours, then there's probably something else going on, or it's more severe like congestive heart failure or a cancer or something along those lines, right? And a lot of your viral ones that just kind of come and go, like when you go to the doctor, that's why usually people like, when they're coming to see you, they've had more than 48 hours of symptoms. But most people don't go to the doc with only 2 days or 1 day, unless you're trying to get on PT or work or something. You know, a sick call, but you're probably not ordering an X-ray at sick call. Profiles. This won't get you a profile. Well, maybe. You can test this tomorrow. Okay. So that's just your main infiltrated interstitial disease, right? Looks a lot like CHF. The difference is going to be how long have they had symptoms for. Is this patient young or old, right? Your CHF is not typically in your younger patients. Okay? I'm not looking at having you distinguish between this and CHF. I just need you to know that CHF is an infiltrating disease, and you can have all of those CHF findings on an X-ray with somebody who's not having congestive heart failure. because they don't have any of those other comorbidities or disease processes that leads to congestive heart failure. So if you're like, why am I seeing this stuff in this 24-year-old healthy person who's just been a little bit sick, but I don't see the pneumonia or anything on the x-ray, I'm starting to see some of this stuff, it's not congestive heart failure. That patient doesn't paint that picture. Okay, they don't have any of those processes to lead that. Their heart's not failing. It's likely just a temporary interstitial disease. Let's give it a couple of days and see if it gets better and treat the symptoms. Okay. Cancers. 4 main types in the lungs. Chest x-ray is going to be your initial imaging. It can show those nodules and masses. Okay? CT will provide a more definitive diagnosis, but the true diagnosis may need the biopsy, as you guys already said before. Because even the CT can't tell you, even if we gave it with contrast, it can't tell you what kind of cancer it is. It can help verify the location, which will make you more confident in your potential diagnosis, but truly the biopsy is the definitive diagnosis. We have got to know what it is and where it's at. Okay. The nice part about the CT is we talked about even with the breast masses, right? There is nice, well circumscribed ones and ones that are kind of spiculated and kind of fuzzy edges, which lead towards maybe, if there's such a thing, a good cancer or one benign tumor versus a malignant one. The CT can help define that a little bit more than the x-ray can, and that's kind of where that would come into play. But again, definitive diagnosis is going to be the biopsy for any of these potential metastases or carcinomas. Okay, so here I am not going to ping you on where the metastases came from, but like before, it's good to have an idea, because what happens for you in your clinic, all right? So you can kind of make this one an FYI if you want, because I'm not going to ask you where like the most likely area of your cancer is, but I need you to have this, because if you're the one who finds this mass on chest x-ray just because, and it's not like a regular lung cancer, you think it's metastases, you need to know what other stuff do I need to test to find out, or what other questions do I need to ask to start doing that evaluation and diagnosis. Because sometimes you will be the ones that find the mass on the chest x-ray first. And then you gotta go, okay, colon, renal, or is it more likely pancreatic, stomach, what's going on based off of the x-ray, okay? I am not, this is gonna be for a little bit of pulm, a little bit of heme when they get to some of the cancers and stuff. I'm not gonna ping you on these things. I am gonna talk to you about all of these. So, let's take a 10-minute break, and then at the top of the hour, we'll start jumping into all these other disorders. All right. So we covered some of the interstitial disease, we covered some of the alveolar disease as generalities to help you understand kind of one versus the other, what it looks like, why would one be presented, why would one not, primarily with symptoms, how it looks on x-ray. That's an overarching umbrella of things, right? Very generalized. Which means if I'm studying and I'm doing a test-taking strategy, and I were to say, well, how's he going to distinguish between interstitial and alveolar disease if it's on a test in the generalities? Well, I got to have 5 answers. Kind of hard to do when we talked about 2 main topics if I'm just saying interstitial versus alveolar, right? It was designed to give you that understanding, that foundation, so when we go into different conditions, you can kind of put to yourself, hey, this is an interstitial disease, I can see the lines, or I can see the nodules, or hey, this is a patchy area, this is an alveolar. Because again, if you understand why things look the way they look, then you'll eventually be able to take certain diagnoses and rule them in or rule them out as possibilities based off of how they look, okay? So, we're gonna get into all of these abnormalities that look very similar, but also have little nuances to help you tell the difference between them. Okay? Let's start with atelectasis or an opacified lung. What is atelectasis? Atelectasis is basically some kind of obstruction in the bronchioles that causes a lobar collapse. Okay? Causes a lobar collapse. What does that mean? That means I have lung tissue that is supposed to have bronchioles throughout it full of air. Something gets obstructed. One of those bronchioles collapses. Other ones collapse. I now have more lung tissue collapsing on itself, causing a more radio-opaque, dense area on my chest x-ray, called atelectasis. They collapse, okay? What can happen when you get that obstruction in the airway for whatever reason, I don't care what the reason is, I have obstruction. It can be due to multiple reasons. Within a day, the air distal to the obstruction gets reabsorbed by the alveoli, and now there's no air in there, and that's what starts to cause that collapse and that radio-opaqueness of that tissue because there's not air in that section of the lung anymore. So think a straw, right? You have a straw that has air all the way through. If you put a little pea into the straw, everything distal to that straw, the air will disappear, and it just won't have any air anymore. It would collapse on itself. If you continue to try to suck on that straw, it would kind of close. That's kind of what happens. The air exchange still happens distal to the obstruction until eventually there's no air to exchange, and there's nothing in there, and it collapses on itself. We'll see what that looks like in the picture. What are your symptoms? Well, just like everything else, dyspnea and chest pain. Dyspnea and chest pain. On your x-ray, you're going to have a lung opacity in the affected area. You'll see what that looks like. A shifted mediastinum to the affected side in your x-ray. Look at the mediastinums, which are the severe ones. You will see shifting and moving of that area. And you might have an elevated diaphragm on the affected side, maybe, right? But the shifted mediastinum is going to be a big one. So it can happen when there's a whole lung collapse or a lower lobe collapse, right? For the whole mediastinum, you can have a tracheal deviation, shifting, depending on the atelectasis. We're going to see what each of these looks like, and I'll explain why it happens that way in the picture, okay? You can have a hilar displacement, a lower, either upward or downward. You can have a shift of the fissures. You can have narrowing of the intercostal spaces. All these different things can happen with an atelectasis. Okay? So understanding kind of what's going on can help you with the diagnosis a little bit. We're going to talk about the volume loss. It appears whiter, more dense, more radio-opaque. Okay? These are the three guys you're going to be looking at for the most part as far as the shifting. And sometimes you can have overinflation of the other lobes or the contralateral lung, right? Because when I have space missing, right, the chest is a vacuum, something's going to take it over. Right? It doesn't just sit there all the time. Sometimes things will take it over, and we'll see what that looks like as well. These are all words to paint a picture. There are different types of atelectasis. Okay? Obstructive atelectasis is the most common. Obstructive atelectasis is the most common type of atelectasis, primarily because obstructive doesn't always mean a foreign body, right? If I have pneumonia and there's fluid in that and it blocks it up, that's obstructing the airflow, right? The pressure from the pneumonia can cause those to collapse on itself and obstruct airflow. If I have an aspiration, that gets in there, that can be obstructive. If I have a mass and a mass is pushing on portions of my bronchioles, that can be obstructive. Obstructive doesn't always mean within the airways. It's anything that is obstructing the airways in the bronchioles and getting air throughout it, right? So anything that affects the reabsorption of air from the alveoli.
Somebody's on the vent, atelectasis is a concern, right?
Yeah, we will talk about that. So there is of less concern if you're on a vent for atelectasis, and we'll talk about why, okay? I'll briefly mention it right now. The atelectasis is why we get concerned post-op, why patients have to constantly, if anybody's had surgery and they've been hospitalized for a couple of days after surgery, they always do that thing where they come into that little breathing thing, and they're like, hey, I need you to take a deep breath in, and just really blow it out. Take a big deep breath and blow into this tube. What they're doing is they're trying to force you, because you're just lying in bed and you're hurting, so you're not taking full deep breaths. So the concern is in those distal areas of your lung, you're not using those airways, they kind of collapse on themselves from not getting used from the inflammation from a surgery or just some surfactant building up. So they're trying to get you to open those airways up to kind of pop them open to avoid atelectasis from happening, which is why patients on a vent, it's very unlikely for them to have this if the pressures are right, because it's popping those things open for them. It's helping kind of keep the airways open.
Which category would that post-surgery fall
That'll be, again, obstructive. Obstructive. Because what happens is that with the post-surgery thing is that because they're not getting used, they collapse on themselves, so now they're obstructing the airway, the distal airway, and so it just continues to go. Most of it is obstructive because of the fact of just the nature of kind of how it works. It's really what I need you guys to know. You can have subsegmental sort of, and I'll show you a couple of pictures of that. That's going to be a really small area, but most of it is obstructive. Okay, atelectasis. All of these slides, all of these words explain why, how, but really for this one, use your picture to kind of help you out with this. Okay, so it's usually, I'm going to use this center one here, a nice triangular kind of area. It can be big or small. Radio-opaque density in the lungs. So I have it here. I have it up here on this one. I have it over here. It's like this whole area here. Okay. On my lateral, it's kind of like hard to see on that one, like where that's the triangle, but together when I use this. And it's almost always going towards the center, towards the mediastinum. Okay? So this is showing you a few abnormalities. What you're seeing on that lateral view is because of the atelectasis, this line here that's pulling up, that's the transverse fissure. It's one of the fissures being pulled up. So what happens with atelectasis is all of this stuff is collapsing on itself and it's pulling things over, right? Because of the collapse and the pressure. It's pulling it. So look at my trachea on this bottom picture here. Do you notice how it's not lined up with the spinous processes? It's because the atelectasis is starting to pull that mediastinum over and those parts over a little bit from the pressure of the collapse of the tissue. It's creating pressure and pulling it over a little bit. So when you see things like this, and you see a mediastinal shift or a tracheal shift, a tracheal deviation, that leads you towards atelectasis. If this was a pneumonia, I would not have any shifts of my mediastinal structures. If it was just a pneumonia. On top of that, I would have a sick patient, fevers, recent illness, or current illness. Right? Atelectasis is not an infection. So if I don't have fevers and I see that mediastinal shift, either via the trachea, the entire mediastinum, we'll see some other photos of it, okay? Or fissure movement of where they're supposed to be, that's leading me towards atelectasis because it's pulling things from the pressure, right? No, you don't apologize for questions.
Would this be what would happen for a PE since it's obstructing?
No, because where is a PE obstructing at? No, where? What body part?
Oh,
In the vessels, right? In the vessels. This is airway. This is not vessels. So different. Good question though, right? So no, a PE is a clot in our vasculature. Completely different from this. This is in the airway. Where's the obstruction? I have no idea. What's causing the atelectasis? I don't really know. I just need to know how to diagnose it. Okay. Let's look at some more. This is what I was talking about in the aspect to where the other lung will take up some of that space. Okay? The other lung will take up some of that space. So take a look at these two images. This is not a technique thing. So I have a small leftward shift in my mediastinal structures, right here. Notice my right lung is way more dark because I'm having some collapse here, so it's looking more dark compared to the other side. But really the biggest thing is this is a left upper lobe atelectasis because here's my fissure, and the left upper lobe has collapsed on itself, and look at what the lower lobe has done. The lower lobe has come up to fill that space. That's why we are so much more darker here on this part of the lateral chest x-ray than we've really ever seen before. And look at how prominent that fissure line is. Right? We haven't really seen a whole lot of the fissure lines on the lateral x-rays. And if we go back to the previous lecture and you look at on the lateral what those upper and lower lobes look like and where that fissure should be, then when you see this, you know that it's your left upper lobe that is collapsed because it's kind of shifted over and it's more condensed. And then your lower lobe has come up to fill that spot. Can we see that one there? How do I know it's an atelectasis? Again, I see that. What's my patient presenting like? I don't have any illnesses, but we haven't had a pneumonia that has crossed lobes necessarily yet. Right? Can you have multilobular pneumonia? You can. Yes, sir.
So can you just outline the lobes one more time? Like this is the atelectasis.
Yeah, I'll show you right. So this line right here is your lobe. This is your fissure, right here. And so all of this is the upper lobe that has collapsed on itself. It's a whole upper lobe atelectasis. So here's your fissure line, big white arrow. This is the atelectasis, and this is that lower lobe that has come up. So what happened is the upper lobe, you got a whole upper lobe atelectasis, it collapsed on itself, and then the lower lobe in the chest was like, whoa, there's space there to fill. Hyperinflate, fill up more to fill up that space. And that's why it's way more radiolucent and way more dark than normal, because typically this tissue is condensed down here for lower lobe stuff, but it's not, it's expanded out, so it's thinned out and it's kind of opened up. Good? Okay. Yeah, of course. So here is a right lower lobe one. I'll show you where it's at. Right here. It's kind of got a little bit of a silhouette sign there, right? So I'm going to suspect it's lower lobe based off of just this. I can't really make out for sure where that ends and where the lung begins, and I got a little bit more radial opaqueness. In comparison, look at my left side. When the diaphragm ends, I have nice, dark, healthy lung tissue there in the airway space. I don't have that here. On top of that, I recognize that this particular picture, right, I can't see the spine vertebrae, so it's a little underexposed, but kind of trace the spine down. Look at how much right atrium I have. Look at how little left ventricle I have. Why? It's pulling it over. It's pulling that heart and that mediastinum over to the right side. So therefore I'm losing some of my left ventricle from what I've seen. You can also look at the hilum. When you get good at looking at the hilum in the normal, there is a small difference in hilum, right? When you look at your normal x-rays, there's a little bit of a difference between the right and the left, but this is significant. So what's happening is it's also pulling down on the hilum area towards that atelectasis. Pulling is atelectasis, because we're going to look at things that push stuff away. Right? So it's important to know that when it's pulling towards, that's an atelectasis, because we will look at things that push things away, and that's going to be your distinguishing factor of one or the other. Here's one that I can't really see on the PA that well because it's hidden by the heart. But when I compare it with my lateral, first of all, I got spine sign. That's the first thing I have. And then I got this little line that kind of rotates and comes on down. I got a silhouette sign down here on the PA. Right, so you'll say, well, how do I know that's not the heart? Well, let's go back to, do I have a normal one? Where's my normal? Even here with my normal chest x-ray, I can make out the difference between the heart and the diaphragm. There is a density difference, right? So I go back to the normals. If you know what the normal is, then when you get into this guy here, I got my silhouette sign here. I know the blue dotted line kind of hides it, but it's just meant to show you where the atelectasis is. Hard to see because of the heart, but I have silhouette sign, so I know something's abnormal. Something's abnormal. Then I use my lateral, so notice I also have spine sign. So here's my atelectasis right here. Left lower lobe, spine sign, silhouette sign, pulling fissure down a little bit. Yes, no, maybe. I know. Here's one in the right middle. Yeah, okay, right. So, yeah, good question. I should have clarified, so thank you. He asked, can you tell me how it's pulling the hilum down on the lateral film? I can kind of see it on the PA, but not the lateral. The hilum pulling is going to be a PA evaluation, not necessarily a lateral film evaluation. Okay? And the reason for that is because the hilums kind of superimpose on one another, so when you separate them, they're not as prominent. So it's kind of hard. I know my hilar is in this region here, but it's kind of hard to see where that's at compared to the other one. So we use the PA to compare the two hilums to look for the pulling. So, good question. Here's a smaller one. Okay. Right middle lobe, atelectasis. See if you can find it before I point it out. Okay, here we go. So first, I have a little bit of a silhouette sign right here. I can't make out where my right atrium ends and where whatever this radio-opaque area is. I can see the spine area, but I can't really see that clear-cut line of the right atrium of the heart. So now my brain's already thinking something's going on in the middle lobe based off of the chart that we had before. Luckily, I have a lateral image here to look at, and when I go through, this is my triangular radio-opaque area. Now that can get tricky because it's almost in line with those axillary ribs that are coming across, right? But what do ribs not do? Ribs don't come to a point. Also, this is more radio-opaque than all of the other ribs in this section. So yes, it does look like it could be overlying a rib area, but it's those other signs that tell you that it's not a rib. So it's this small little triangular guy here, right in the middle lobe. That is my atelectasis right there. It's pointed towards the hilum, which is a mediastinal structure, so that makes sense, because a lot of these things will point, especially your obstructive ones, will point towards the mediastinum. Sometimes your subsegmentals don't, but your obstructive ones a lot of times will. But we're not far enough gone yet for us to notice any hilar issues in the PA. Kind of hard to tell. Maybe that's the hilum, maybe, but it's kind of small and it's kind of hard to tell. So because this one's so difficult, I wouldn't have you guys pull it out with just the hilum. You can use it if you want, but in reality with the silhouette sign and the lateral of this, that's where I know it's an atelectasis. So let's just do this versus pneumonia too, right? Besides symptoms, what are other things, what is another main thing of pneumonia versus this one that can help you kind of distinguish between them off of how the image looks? What is pneumonia? It was in what category of disease? The alveolar air space disease, which was what? Patchy, fluffy, hard to see the borders all the time. These are pretty clear borders. So if I were to combine what I know about pneumonia, that it's a patchy alveolar disease, along with the fact of does this patient have any sick type symptoms, that should be a good portion to help me go atelectasis versus maybe pneumonia, right? Especially when we're at the stage to where there's not a whole lot of pulling going on yet because of where it's at, right? My mediastinum looks like it's where it's supposed to be. Outside of that silhouette sign, everything is pretty well lined up where it's supposed to be. Because it's a smaller one, it's an early stage. So this just goes to show that not all of them will pull the structures over. But it's something you should evaluate and look at when you're trying to distinguish if there's one there or not. Okay, questions on that so far? When you do radiopedia, look up atelectasis, you're going to get a lot of different things. A lot of different things. So if it just looks crazy, find a different image, right? Try to get an idea. Lung stuff is really difficult to find just one disorder with. Sometimes you can get more specific if you want and do like, it's a little bit easier if you do like right lower lobe atelectasis or right middle lobe atelectasis. That might help narrow it down just a little bit more so you at least know where you're looking to help get you an idea of what you're looking at. FYI, okay, if you have an atelectasis and it meets any of these categories, you need to get a bronchoscopy or a CT scan. Not testing you on that, but this is the next step. If any of these things are occurring, most atelectasis, I don't know what the plural is, most of them self-resolve. Most of them. Unless you hit these categories, then you need to do further evaluation. Oh, there it is. Hours to days based off of location and size. Okay. If you have a lobar, a whole lung one, yeah, it could be patchy. You know, I just said, hey, that's how you administering pneumonia, and it had well, then I'm not going to make you just, right? Pneumonia or atelectasis, that's an advanced type thing. But they will most likely kind of resolve on their own. So it's just really patient observation, you know, making sure they're breathing, taking full deep breaths in, kind of like that post-op thing we talked about. Questions on atelectasis for now? It's a no now, but I'm sure you'll have a lot of them. Yeah, what's up?
Because the epithelial lining of the alveolar sacs have collapsed, do we ever see damage of that epithelium?
That's a good question. I don't know the answer to that one. I haven't heard of anything as far as like long-term damage after atelectasis gets better. But from the pathophys standpoint, I would suppose it's possible. But it's not common enough to actually be part of like the treatment plan and to be worried about afterwards that I've read or studied up on. So I'll ask Dr. Cole that for a poll. I'm kind of curious now too. I don't know. Let me find out. Okay. So we talked about atelectasis. Now we're going to talk about pleural effusions. This goes back to that silhouette sign a little bit, okay? So someone had, I had a couple of good questions again on the break as always, is when they look at that silhouette sign, sitting in that hemidiaphragm, it had that nice sharp costophrenic angle, and they're like, well, hey, why is it just there and not over the whole hemidiaphragm? Because remember the silhouette signs, especially when you're looking at like a pneumonia or something, sit in the alveolar airspace, right? So they're going to sit there. They're not in the pleura. The pleural effusion is fluid in the pleural space, and that gravity is always going to bring that down, and that fluid is going to fill up those costophrenic angles. So costophrenic angle blunting is a pleural effusion, right? What is it? I don't know. It's fluid. Could be blood, could be pleural fluid, could be anything, because fluid just looks the same on X-ray. So this is what it is. It's fluid within the pleural space, right? And this is why we need that upright chest X-ray. Now we can do something which we'll talk about a little bit later called decubitus. We'll talk about what that is. because that is something that you have to order specifically if you want it. It does not come standard. But this is what, look at how, it's like, oh, that's only a little bit of fluid. That doesn't look so bad. But in reality, when you lay them flat, and you see kind of where that fluid kind of goes, that little bit of fluid is actually a lot of fluid. Because again, in order to see it on that PA chest x-ray, you need at least 300 milliliters in order for it to even be noticed on this upright PA. That's a lot of fluid to be sitting in that pleural space. And then how many milliliters do you need to see it on the lateral? 75. 75. Good. So here's what that looks like. This is a severe one, right? But that pleural space keeps filling with fluid, and we get these lovely air fluid lines, right? So fluid fills up and fluid stops, and it's like a glass of water. You just see it right there in that glass of water. This here is that decubitus one. So they're lying them on their side, so they can kind of get an idea how much is actually there in that lung from the thorax and kind of up, so it kind of gives them a better picture, a better measuring tool. Because here's the thing with this guy. So I know you have a pleural effusion. How much? I don't really know, right? I don't know where it started and kind of where it went up to. So it can be difficult to kind of evaluate how much is right here. Radiologists have measuring tools and things along those lines. When you do the decubitus, well, they know for sure when you lay on your side that lung tissue should go all the way to that thorax wall. So they can actually do some kind of funky calculation thing and figure out about how much fluid is sitting in there. It's kind of hard to tell from this one. What's this? I heard EKG, I heard pacemaker. Anybody ever hear of a port? It's a cancer patient. This is their port. So for anybody who's had a family member who's gone through like chemo and things along those lines, or dialysis, it really wrecks the veins in the arms really bad. So that what they'll do is they'll put this port in, it's direct access into the bloodstream there to be able to give medications or things along those lines. You see this in a lot of cancer patients and a lot of dialysis patients. They'll have a port permanently kind of placed for any type of medications and things that they may need. All right, so what causes a pleural effusion? Lots of things. Lots of things. But what are some of my symptoms? Non-productive chest or non-productive cough, pleuritic chest pain, tachypnea, low-grade fever, some dyspnea, and possibly the trypopnea. Trypopnea is basically worse dyspnea when lying on one side. Which side do you think it's worse? When they're lying on the side of the pleural effusion, right? So how would that look like if a patient, yeah, it's been weird, I've been coughing for like the past few months, just been really coughing a lot, and not coughing anything up, non-productive cough, haven't really been sick, because I have low-grade fever, and kind of get this intermittent chest pain, and then it's the damnedest thing. Like, I can sleep on my right side, but like if I try to sleep on my left side, like I have a hard time breathing, right? That's how that patient's going to say that to you. They're not going to say trypopnea. They don't know what the heck that is. But their description when they're telling you their symptoms, they're going to be like, yeah, I just, how's sleep going on? Right side fine, left side weird. Like I can't do it. I always have to sleep on my right side, which is weird because I've always been able to sleep on my left side, and now I can't. Okay? X-rays your initial study. You get that PA, and then when you see it, possibly that lateral decubitus, you do have to order that special. That is not standard. The lateral decubitus is not a standard picture. All right. We already kind of covered some of these other things, but PA 300 milliliters, blunts the angle. Lateral, says 50 to 75 there. 75 is where you're going to go at. 75. Has that meniscus shape because it's like the water in a glass, right? And have that meniscus kind of fluid sitting in there. That's how you're going to see those pleural effusions. There's not really a study of choice in this one. It's really getting the chest x-ray. Yes, a lung ultrasound can be more effective in finding the really small pleural effusions. The problem with that is it's operator dependent. right? So unless you're really good at looking for these things with an ultrasound, it's very, very easy to miss on the smaller ones. And a CT does have a higher sensitivity in the chest X-ray detecting pleural effusions. But again, that's a lot more radiation, and I can see them on a chest X-ray. So there's really no need to do additional imaging. You can if you absolutely want to, but chest X-ray is going to be all you're really going to need to diagnose this. Here is the pathophys of what happens, FYI slide, I'm not going to assess you on pathophys, of what happens when it causes pleural effusion, okay? You have one of two things, or sometimes both. Increased rate of formation of your pleural fluid, so increasing hydrostatic pressure, decreasing osmotic pressure, primarily liver failure. We see this a lot. We see pleural effusion in the patient with liver failure because of the decreasing osmotic pressure, so you have more pleural fluid being created. Increased permeability of the capillaries, so like an allergic reaction, somebody who recently went through an anaphylaxis or something along those lines could be prone to pleural effusions. And then less likely your lymphangitic blockade, so tumors primarily, so lymphoma, that kind of thing can cause it. And then decreased pressure in the pleural space, so if there's a pleural space atelectasis, which we didn't really talk about, that can cause some issues if it's on the pleural side, or a lot of it we didn't like the mediastinal side. These are just reasons why we end up with more fluid that are non-trauma, right? The other one is trauma, and they're bleeding into the pleural space. That throws all that out the window. But this one breaks down transudative and exudative, FYI slide, right? But look at the types of patients that can have pleural effusions. Again, this goes down to the why do you have a pleural effusion? A pleural effusion is not a disease, it is a symptom, it is a finding on X-ray, and then your job as providers later on, once you get all this knowledge, is to figure out why. Why do they have a pleural effusion? Right? In our field, for those of us who are going to be treating active duty medicine and working in the military after this, trauma is going to be probably the most common thing you're going to see. But for those of us who are going on to the outside, right, CHF or malignancy, which basically is just another word for cancers, are probably going to be more common that you're going to see when you're treating the general population. So really for all of us, eventually once this comes off, it'll end up being CHF or malignancy if you still decide to practice medicine after the Air Force and the Army beats you with a stick for 10 years and you get out. That's what I decided to do. But, here's all your causes of pleural effusions broken down. Dressler syndrome. Okay. Dressler syndrome is the one on here that I don't want you to miss. You need to know Dressler syndrome. This is a patient who has a pleural effusion, often post-MI. Post-pericardectomy syndrome, really post-MI. Within a couple of weeks, they start to get sick. They have a fever. They have chest pain. You get the X-ray. You see a pleural effusion. You might even hear a pericardial friction rub, which is pericarditis. Okay? That's a Dressler syndrome. I even gave it its own slide. I recognize that the lung tissue on this X-ray is trash. I recognize that it's underexposed. I don't care because I'm showing you the pleural effusions, which you can see clearly with the bad technique, right? Primarily on this side right here, the blunted costophrenic angles. Okay? This is what I want to stand out to you guys, so I know we can't do our stepwise process. And if I were to ask you if this was an adequate chest X-ray, you would say no. What is this trash? I can't do what I need to do for my systematic process. But in this particular case, it's really great at showing the blunted costophrenic angle due to the pleural effusion. So if this person was post-MI, had this, had a pericardial rub or fever, I'm thinking Dressler syndrome. It's a diagnosis you cannot miss. You will go over it more in cardiology, but this is one that you can do with just an x-ray and a patient history. You can diagnose Dressler syndrome. Gotta have this first part. Gotta have the post-MI or the post-pericardiectomy. It's not cardiotomy, it's cardiotomy, sorry. Pericardiotomy syndrome. Fix that. But then with pleural effusion and either the rub or the fever. It's gotta be post-MI. Can't have Dressler syndrome if you're not post-MI. Look at all the different things. Okay, so we're going to start to go over all of these little effusions, giving you more tools to notice a pleural effusion when you see it. Trying to arm you with many different ways to pull this out. Okay? Subpulmonic effusions are between the visceral pleura and the diaphragm, usually free-flowing with position changes. You'll see why that's important here in a little bit when we get to some of the other slides, okay? So almost all pleural effusions are going to be in the subpulmonic location beneath the lung, between the surface of the diaphragm, and that's kind of where we're at right here, in the lung tissue. Subpulmonic, below the pulmonary tissue, okay? Now, what does this do? As we saw on the decubitus, when I lay you on your side, it's going to spread out. It's free-flowing. It's not locked into this area. When I move the patient, I move the patient. If I were to stand them on their head and take an x-ray, don't do that. But if I were, it would all be up here because gravity is going to take that fluid and move it into the upper area of the thorax, right? It's free flowing. It's not locked into anything. These are all the effusions we've been looking at already. We've already been looking at these ones. They're technically called subpulmonic effusions. We just lump it into a pleural effusion altogether. Okay? Here's some more. Right here. See the nice sharp point I have down here? The A's in the way, but a nice sharp point. I don't have that here. Down here. Right? See that nice little area there? Don't have that there. Kind of pushing up there a little bit. A little bit of meniscus sign there, but what do I have right down here? What's this? What do we call this area? Spine sign. It's just a generalized term, spine sign. Something's going on. What do I have? I don't know. Oh yeah, I do. I got a pleural effusion. Look at my PA. Another slide here for blunting of the costophrenic angles. 300 milliliters in order to see it on the PA. Repetitive for a reason. Yeah?
Is that centralization
Yes. Yes, it is. What could be one of the causes of pleural effusions? CHF. Right? So again, and I'm glad you asked, because yes, it is cephalization. Yes, this is a patient that has congestive heart failure. Yes, that's a pleural effusion. Read the question first. Okay? Then read the answers. Because these are what a lot of them end up looking like. It's just so hard to find sick patients with just one abnormality on a chest x-ray. Meniscus sign. I briefly showed it to you, but here's its own dedicated slide to show you the meniscus sign. Just like in chemistry class, when you used to fill up your little graduated cylinders and figure out how many milliliters. You just see this. It's the same concept. The fluid is sitting in a tubular area, right, the thorax, and it comes up and you have a meniscus sign. Now, usually you only see this on the ones that are pretty severe, that have a lot of fluid in there, because I got to be able to fill up the whole side of the thorax, and then you can see it. You don't usually see it when it's just like a little bit down in here, because there's not enough yet to really create that full-on meniscus sign from basically the mediastinum over into the wall of the thorax. Oh boy. That's a problem. What's going on here? I have an opacified hemithorax. It tells you at the bottom of the slide. The entire hemithorax is filled with 2 liters of fluid. Now here's the fun question. Could that be, if I didn't put that on the bottom of the slide, and I just gave you that x-ray, could that be a whole lung atelectasis? Yes, it could. That could be an entire lung collapse. How do I tell the difference?
Push or pull.
Look at my structures. Atelectasis pulls things over because of the pressure. Fluid pushes things away. Fluid pushes things away because the pressure now, instead of being pulled, is coming from here, pushing that way. So when you see an entire opacified hemithorax, you're trying to figure out, is that fluid or is that atelectasis? What is happening to my trachea and to my mediastinal structures? They're being pushed, which means that lung is filled with fluid versus pulled. Because on x-ray, I will tell you, a whole lung atelectasis looks exactly like that. The difference is, where are those structures going? Symptoms, very similar. Shortness of breath, dyspnea, probably some chest pain. Now there's no reason to get a decubitus on this patient because the fluid is not going to go anywhere and fill the entire side of the hemithorax. So I already know that because it wouldn't be filled all the way up here if it wasn't all the way. So there's no reason to do that, right? How stable do we think this patient is? Probably not very stable, and if they are, they're not going to be for long. What's that? They're not stable enough for a CT. No. And they don't even need a CT. Don't send them to CT. Don't send them to CT. Goodness. All right, so as far as the question there, right, yes, they're hemodynamically, they're probably unstable. This whole acute versus chronic area down here, right, does it make a difference? No. No, because what am I going to do? What's this patient going to get? Chest tube. Drain this. We're going to drain this out. You guys can do this. You get the practice at senior semester. On each other, no. Hey, it's military medicine. Don't be surprised if you did that. Yeah, you injected, you guys went to the dental lab, right? Well, test tube lab, it'll be fine. All right. Loculated effusions. This looks different. Why is it floating here and not filling from the bottom up? Because it's trapped, loculated. It's locked into an area. Nice part about loculated effusions, when you do that decubitus, it doesn't move. It stays within that enclosed area. So it's really easy to diagnose. You look at it and you go, okay, well that's not how pleural effusions look, but I definitely have fluid kind of going down in this area. I have some blunting there, but I have space between. It should be like this. Let me get that decubitus. You get the decubitus, it doesn't love. Like, okay, I got a loculated effusion. Still a pleural effusion, it's just locked into one area. Usually what ends up happening is we end up having adhesions in that pleural space. So it's likely adhesed down here. And so that's what's stopping it from going all the way down. And so it's kind of locked into a certain area in the pleura. Yeah?
Are they always going to show up like laterally, or can they show up anywhere?
Usually laterally, because that's where your pleural space is. Right? So it shouldn't be showing up kind of in here, because these are pleural effusions and your pleural space outlines. I mean, it can come on the inside, right? But it's almost always lateral. It's just that I got the heart and stuff in there, so it's really hard for it to kind of do that on its own. All the ones I've seen have always been lateral. Pseudotumors, also trapped, right? Because they're within the fissures. So it's fluid in the fissure, doesn't change with position changes. A lot of times, those are cephalization, congestive heart failure patients, right? So if I trach up, look at same density going up, like we talked about before yesterday, same density level going up. I don't get darker like I do on this normal x-ray here. Darker up, same density. And then I end up having this fissural pseudotumor. So it's just basically the same concept as the loculated ones. The difference is this time it's trapped in between layers of the lobes of the fissure area. Your cousin, the curly V lines, your laminar pleural effusions, FYI, I'm not, right? But they can be there. That is a thing, still trapped as well. Won't change your positions. The one with the 2 white arrows, and the black one is showing you the borders of the rib, and then you see your loculated or your laminar effusion right here. See, that's different, but not touching me on that one. It's just a pleural effusion. So here's a hydropneumothorax. Don't get hung up on the pneumothorax part yet. Okay, the white arrow is pointing to the pneumothorax. We haven't learned to find those yet. But technically, a hydropneumothorax is a type of pleural effusion, usually caused by trauma, because now we've introduced air, and we got fluid in there. Fluid, hydro. We don't know it's blood until we put the chest tube in there and it comes out. X-ray can't tell us it's blood. Pleural effusion fluid or pleural fluid and blood look the same on X-ray. Most of the time, it's blood. Because if I have a fluid, and what you haven't learned to look at yet, but if you look very, very closely, you will see a lung line right by that tip of that white arrow, and you'll see no lung markings in black between that arrow and the chest wall. Right in there. That is your pneumothorax. We will look at that more probably tomorrow and really kind of break that down of how to find those. But this goes in the pleural effusion category because we have the fluid as well. So that makes it a hydropneumothorax until we confirm it's blood. Then once we know it's blood, it becomes a hemopneumothorax. But based off of just x-ray, it's hydro because we don't know what that fluid is yet. All right, once the chest tube goes in, we see dark red blood coming out, then we can call it what it is. We will stop there. I will stay up here for any questions, right? Lots of different pleural effusions. Understand what they are, understand how they move, which ones don't move with a decubitus. So if you get an x-ray of a PA and a decubitus, and the fluid stays the same, you have an idea of which ones it could be versus if it doesn't stay the same, right? If it kind of moves around. And understand some of the signs of being able to see it. The meniscus sign, that's how I know that could be fluid in there. The pushing of the mediastinal structures in the trachea versus the pulling of the atelectasis. These are the things that will tell you the difference between the two. All right, so go ahead and go on break. I'll hang out for a few questions. See you guys tomorrow morning.